Before we move on to questions from the audience, I want to ask each of you one question. And that is, if you can, I'd like to give each of you the opportunity to tell the audience one question that you would like to answer soon, see answered soon about this field. What's the most important question to you in your research, or that you think, whether it's yours or somebody else's, what's next? What's the question that you want to know?
Where are we starting?
Only one?
Only one each. One each. Your favorite.
Okay, I think my favorite is that I hope that during my career we will be able to sort out, when we make a diagnosis of breast cancer, which is a breast cancer that is a very difficult one, and where we know that we need to go in with very aggressive therapies, and which would be a breast cancer which we would think might be relatively well behaved, if one could say that, and where we would not need to, that the patient would be able to take her therapy and get on with her life and think of that as a small speed bump on the way to the rest of her life. So how to differentiate between the so-called good cancers and the bad cancers, and then how to address them appropriately, that personalizing of care.
So the question I hope gets answered, and one we're working hard on, is to find more effective therapies for the triple negative or basal-like breast cancers. This is one of the newer subtypes that's sort of become biologically and clinically appreciated, and I hope we can get sort of the Herceptin for that.
And triple negative means no estrogen receptor, no Herceptin receptor, and no progesterone receptor.
That's correct.
Okay.
So they lack.
And those tend to be bad. So you have, okay.
Tend to be bad, have a worse prognosis, more frequent in younger women, and so we really need improvements for them.
I'm old, so I have to make an impact quickly. So what I would like to do is, from what we know now, develop combination therapy that will cure or permanently repress hormone-dependent and HER2-dependent breast cancer, and then work with Chuck on what he finds to do the same thing in triple negatives.
Well, if Neal fixes that, see, then I would say that to me, trying to identify mechanisms to address how to improve the outcome for women who have these very aggressive tumors, who are at high risk for early recurrence and who don't respond to our standard therapies. I'm very hopeful that some of these immune approaches and reprogramming of the immune system may be successful. And I think that if we can figure out that, we could make a very big impact. So it's, if you get the late risk, we get the early risk, and the rest are idle and everyone else is going to be cured, then we can make this something that people don't have to worry about.
So I'm impressed by the speed with which the genomics revolution is coming in our direction. The molecular biologists say that we're at most a few years away from what they call the $1,000 genome, the point at which, the sort of inflection point at which, in essence, every patient in the United States ought to be able to look at every single mutation in every cancer. What are we going to do with that information? When we are able to actually measure every single mutation in every patient, how are we going to use that data to bring about a cure for those patients? I think that's going to be the measure of how well we do in the next decade.
Thank you. Thank you all.